Okay. Welcome everyone. Welcome to Asthma Grand Rounds. We're really happy to have you. We today are going to be talking about the impact of climate change on asthma and allergies. I'm going to go through a little bit of the housekeeping and then introduce our speaker, Kari Nadeau. So remember, this is a live webcasting. You can submit questions to our speaker by entering them into the chat. If you'd like CME credits, you can email your name and your degree to eIsraelAssistant, EISRAELASST at bwh.harvard.edu, and we will process the CME for you. If there are any technical problems during the live broadcast, you can send an email to BWH Webcast Troubleshooting, all one word, BWH Webcast Troubleshooting at partners.org. And today we have the extreme pleasure of having Kari Nadeau, who's the head of the Department of Environmental Health at the Harvard T.H. Chan School of Public Health. She has published over 400 papers, many in the field of climate change and health. She and a team of individuals and patients and families have really been able to make major progress in the impact in clinical fields of immunology, infection, asthma, and allergy. She's a member of the National Academy of Medicine and the U.S. Environmental Protection Agency Children's Health Protection Committee. And for more than 30 years, she's devoted herself to understanding how environmental and epigenetic factors affect the risk of developing immune dysfunction, especially wildfire-induced air pollution. And we're so happy to have you, Kari, and we're really looking forward to having you share your expertise and your experience.
Thank you so much. It's a pleasure to be here. Can everyone hear me okay?
Yes, I believe so.
All right, great. I'm going to start sharing my screen. It is wonderful to be able to be back where I originally trained as a medical student and for my Ph.D. in biological chemistry. And to me, it couldn't be more important to be able to be back here talking to Asthma Grand Rounds about the impact of climate change on allergies, immunology, and asthma. And I know we know as physicians and as scientists and as researchers and healthcare professionals that there are a lot of issues with climate change and health. But what I'm going to be doing today is making sure that I explain the problem, but also explain some of the solutions and how we can best move those forward in terms of action and quantification of testing those. So I'll begin with just going through some of the effects of climate change on planetary health. We understand that fossil fuel-driven pollution is a major issue now among our global population, worsening sandstorms, worsening wildfires, overflooding, temperature increases, and changing patterns in infectious disease. And particularly today, I'll be focusing on those issues around climate change that affect health care systems as well as health-related illnesses pathologically specific to respiratory disease and allergies. But I want to make sure that everyone here understands that these health risks for any one individual can be compounding over a lifetime and over multiple exposures. There are what we call environmental determining factors, and those determining factors are like social determining factors, where we're looking at vulnerability factors, exposure pathways, and also as we think about people's access to healthcare, in certain situations with extreme events and how that might affect asthma attacks, there can be an overburdening of the healthcare system. So today we'll focus mostly on respiratory illness and allergy as it pertains to health outcomes and climate change. Now, why does everyone worry about this? Well, I think that I don't really need to belabor this, but of course, with higher atmospheric CO2, sea level rise, floods and droughts, higher temperatures, that then moves forward in terms of associated pathways and cause and effect pathways with certain mechanisms. For example, we'll talk today about wildfires, water shortage, and ozone and particulate matter. And then conditions and diseases then have pathological mechanisms by which these certain mechanisms yield health outcomes. And importantly, who is affected by climate change? We all are. For example, UNICEF has written a report now saying that for every child born on this planet today, they will suffer through at least one extreme climate change associated event. But when we think about those most vulnerable, or those that are inequitably exposed to climate change as well as to environmental exposures, they include the underserved and the under-resourced. As many of you know, the majority of people that live near a toxic waste dump or a polluted area are people of color, unfortunately, due to some colonialization and laws in the past, both in the US and other areas. People with heart or lung disease are already at a more vulnerable, sensitive position when it comes to being exposed. Older adults are at risk, especially for cardiovascular disease, respiratory disease, and stroke. Children are very much at risk for asthma attacks, both acutely and then potentially chronically, because of the metabolism and breathing more air per pound of body weight, for example. When we think about particle pollution and timing and when that would be, and climate change is associated with air pollution because air pollution has been one of the root causes of the CO2 increase across our globe, we think about the variety of different particulate matter, including windblown dust, combustion sources, cars and trucks, industry, power plants, and fires. These fine particles are emitted directly into the air and they can form gases. And unfortunately, as they trail, especially wildfire smoke, they tend to age over time, but they tend to split into different products from a chemical standpoint. And so they don't necessarily get less toxic, but sometimes actually more toxic as they move across the globe. Particle pollution can occur year-round. It can be worse in the fall and winter, depending on where you live. And we saw that here on the East Coast, unfortunately, with the recent Canadian wildfires this summer, and our skies were orange in Boston and New York and in Washington, D.C. But I think for us as healthcare professionals and scientists in this field, I want to focus on the worsening of allergies and asthma, specifically as they pertain to these climate change associated events: heat waves, pollen increases, dust storms, wildfires, air pollution, biodiversity. And when that IPCC report, which I show the cover of, came out, and it's come out for a number of years now, it says that we are in red alert. And this was made very carefully and thoughtfully by the Intergovernmental Panel on Climate Change. This is a report written most recently in 2022. 270 countries participated in this evidence-based report. 67 scientists and authors also reviewed the material. So if people are interested, there is a summary in the report. But what I do here is put a figure together just to explain some of the climate change associated events. But of course, in any one individual, they're getting exposed to environmental substances, microbiome and dysbiosis, as well as other behavioral changes that over time, with epithelial barrier hypothesis, lung and skin issues and intestines, that can be associated with asthma, allergic rhinitis, atopic dermatitis, food allergy, for example, all within the spectrum of what we're talking about today for our grand rounds. But importantly, what are the mechanisms? What are the actual mechanisms behind how climate change associated events can affect our bodies? Well, that's where, when I wanted to start looking at this back in 2009, I worked in the Central Valley, and many of the individuals there, when I talked to the community, were worried about their children. And so it made sense to me to look at epigenetic pathways. And so, of course, many people know about epigenetics that can occur at the single cell level. There are many mechanisms by which epigenetics are controlled: DNA modifications, chromatin structure, histone modifications, nucleosome positioning, chromosome structures, as well as RNA. And with that, I think the reason also why I looked at epigenetics is because in allergy and asthma, these are canonical pathways that are exquisitely regulated by epigenetic mechanisms. Philippe Beguin is pictured here. He was a fellow in my lab from Canada, and he wrote this really great review showing to the extent that the IL-4 receptor, TCR, Th1, and Th2 pathways are modified epigenetically through histone modifications, through methylation in certain CpG sites and certain loci, and those loci being those that we know well for mechanisms of asthma. And when you look at the whole picture, there's much evidence to say that DNA methylation association studies are linked with allergy and asthma. And you can see here in terms of phenotypes, FOXP3 is an important gene and locus that is affected by pollution mechanisms, and I'll show you that in a minute. There are others as well, which I won't dive into today, but interferon gamma, FOXP3, IL-13, IL-4, all controlled by epigenetic mechanisms. And Mark Rothenberg had a nice article in Jackie in 2022, specifically showing the components of climate change and the effects on asthma and allergy. For example, global warming, extreme weather, affects changes in geographical spread of allergens, air pollution increases allergen sensitization. And so when we look at the multiplicity of these effects, we don't only look at one particular exposure, because, for example, someone living in the Central Valley is exposed to not only heat, but dust, air pollution, and then wildfire smoke. So on any given day, they can be exposed to all four of these items, and to what extent they're linearly additive or unfortunately exponentially additive and affect them acutely or reversibly or chronically and irreversibly. These are the types of questions that we need to understand as the world deals and adapts to these climate change associated events. One of those key associated events is wildfire smoke. And so let's break that down. We've had wildfires across our globe for many, many thousands of years. But unfortunately, as you can see over on the right-hand side, climate scientists have now shown that we have about 50% more of our acres burned because specifically of climate change. CO2 increases, droughts, increases in temperature, and then unfortunately, disease that causes the tree to have bark beetles or to dry out. So with the temperatures rising, this is really a positive feedback circle, as you can see on the left, with snow melting sooner, forests drying out, and temperatures rising, and then wildfires ensuing. This is a great article that was published in the New England Journal, and you can see here again that positive feedback loop as it pertains to geography and meteorological events, where you have increased greenhouse gases, increased wildfires, that increases soot in the atmosphere, that actually warms the atmosphere even more. And so you see this increase in climate change associated events and a tipping point, especially in the polar ice caps. We luckily now, because of many of the policies that have been implemented across Europe, across the globe, we're not there yet, but because there have been some implementation plans, we're kind of more looking at the model over here between D and E, that we expect to see the change in frequency of wildfires increase over time. We are trying to get to model A so that we don't have as many wildfires, but irrespective of that, with the fact that we are on already the trajectory, given where we're at right now between D and E, is what we would expect to see in terms of increases in wildfires around our globe. And why are we so worried about the wildfire smoke? And again, it can circumnavigate the world. If any of you were aware, in Australia in 2019, there were terrible fires in Melbourne, and then Perth picked them up 2 days later. So again, you can track the smoke across the globe. Each smoke, as it were, has a certain fingerprint of chemicals that you can actually track via HPLC and gas chromatography mechanisms. Here's a wildfire that occurred where I lived back before I moved to Boston. I had to evacuate my house 3 times in the past 5 years due to wildfires. And unfortunately, now most wildfires in the West are not purely due to wild biomass burning. 50% are residential or commercial. Most counties in California have 60 days or more of smoky days, as it were. Even when you live hundreds of miles away from the smoke, it can still affect the air quality index of the air. And unfortunately, you can see there the data that's been provided by a lot of epidemiologists that there's been a 50% increase in asthma, for example, especially in children under the age of 5. And you can see the counties there in terms of their quote unquote heat map, there being the wildfire smoke. But it's not just in California, it's not just in the West anymore. You can see in the bottom of the slide that there are other countries that are dealing with wildfire smoke. So what is in wildfire smoke? Why do we care about that in terms of asthma? Well, unfortunately, like I said, it's not really wild anymore. There's particulate matter, there's carbon monoxide, nitrogen oxides, polycyclic aromatic hydrocarbons, volatile organic compounds, trace minerals, as well as toxic metals, and phosgene, toluene, styrene. As you can imagine, your upholsteries are going up in smoke, your detergents are going up in smoke, the paint thinners in your garage, and that leads to a lot of different types of polymers, microplastics, and synthetics. So asthma is associated with wildfire smoke. It's not just like biomass burning, unfortunately, because of these chemicals. There's acute issues for irritation in the epithelium of the upper respiratory tract, inflammation. Your antiviral defense mechanisms become dysfunctional. There's an increase in sinonasal symptoms, decrease in ciliary clearance, and the lower respiratory tract is affected as well with increased oxidative stress, increased sputum and neutrophils, and increased asthma symptoms and ED visits. So what I want to do now is move from that background to a research overview, and again, really focus again for how to solve these issues. And in order to solve them, we need to find out how to track them. And in tracking them, what we did in the Central Valley was to look at asthma status based on NIH guidelines. Physician diagnosis of asthma was self-reported as well as documented in our NIH funded studies. We excluded anyone that had taken oral immunosuppressants or had history or had any other disease steroids. And what I'll show you today are those studies that pertain to wildfire smoke exposure in teens and young adults, again, getting at mechanism and pathology, air pollution studies as well with epigenetic studies, and then importantly, looking at solutions, looking at the comparison of prescribed burn and wildfire smoke, because many people would like to know whether or not managing the forest ahead of time can proactively reduce the risk of wildfires and not harm any humans. In order to study these mechanisms, we in the laboratory, thanks to a lot of immunologists at Stanford and here at Harvard, we were using the time of flight cytometry mechanisms that are now available using new machines that use mass spec as the underpinning of their mechanism by which to look at intracellular and cellular markers of the immune system. And you can do high dimensional immunophenotyping as well as inferring function based on this. So what happens is you label an antibody with a chelator and a metal, and that metal can be picked up. It's shown here in blue dots with a mass spec. Unfortunately, the issue here is that you can get really fine resolution up to 47 different markers at once using Tisney plots. This is a special form of a PCA plot, for example, and defining cell populations in single cell level. But when you're taking it through the machine, it zaps the cells, so you can't do single cell sorting or analyze live cells at the end of the run. So we wanted to apply this CyTOF technology to the samples that we were collecting in the Central Valley. This data had come out in March 2021, showing the association of wildfire-specific PM2.5 and pediatric respiratory health in San Diego County. They looked at visits to the emergency room, and what they found is that the wildfire-specific PM2.5 was found to be 10 times more harmful to children's respiratory tracts than PM2.5 from other sources. Not that PM2.5 from other sources is not a problem, but the wildfire smoke enhances that toxicity. So we looked specifically compared to control groups in teenagers, biomarkers using the CyTOF of inflammation and oxidative stress and coagulation and endothelial function markers. And Dr. Mary Pernicki, or now Dr. Mary Johnson, is pictured here. She ran the study. She went to Fresno every week, in fact, and collected blood and collected all the parameters and oftentimes pulmonary function tests as well in this group of individuals that you can see the demographics here. Most of them are Hispanic. This is an underserved community. Many of them had chronic asthma to begin with. And when we looked at those inflammatory markers and looked at the cellular level, some of the components, you can see overall that based on a Luminex proteomic pathway, that in general, compared to the control group for which there was no or little exposure of wildfire smoke or pollution in general, that the CRP is up. This is a marker we use a lot, and I think that could be a potential biomarker in the future, but you can see there's a wide distribution there. And this was after about 5 days of being exposed to wildfire smoke hundreds of miles away at about an air quality index of 100. You can see the D dimers, IL-18 was increased, IL-1 beta was significantly increased, and then myelin peroxidase. And with that, you can see the cells that were mostly making the myelin peroxidase, for example, were the monocyte populations. And I won't get into this too much, but it's important to then trace back and look at where that IL-1 beta was coming from, perhaps, and that's what we did in our CyTOF studies, and you can see this in the Tisney plot here. What is also interesting is that there was a increase in the aryl hydrocarbon receptor, for example, after the wildfire smoke exposure, and I'll get back to that in other mechanistic work that we did for air pollution. So pausing from wildfire smoke now to air pollution in general using combustion from diesel exhaust, we wanted to frame our next hypotheses around air pollution in general. And just again, giving some people background, air pollution is responsible for about 7 million deaths per year. It's increasing across the globe. You can see in this picture from the World Health Organization, those areas of the world that are responsible for more of the morbidity and mortality around the air pollution. And unfortunately, in California, for example, in the areas of the West, wildfire smoke really has been unraveling decades of air quality gains that we've had. So this is something that we're really focusing on. And I still do a lot of research in the Central Valley because of these issues with compounding effects of air pollution and wildfire smoke. But now with the new World Health guidelines, 80% of the world's population of children live in areas exceeding the WHO standards for air pollution. And this was published by our colleague Mary Rice and Diane Gould across the Harvard medical areas in JACI in 2021. So it's not just about having wildfire smoke or air pollution worsen an already extant asthma condition, but also many of you are aware that this review was published in the Environmental Health by Bettiol et al., showing that of the first 1,000 days of life, traffic-related air pollution actually causes development of wheezing and asthma in childhood. And this is a systemic review of birth cohort studies, and they found a positive association between PM and nitric oxide species. And so you can see there's some of the mechanisms that have been worked out in animal models, for example, and primate models, showing the importance of the MUC pathways, aryl hydrocarbon receptor, TSLP pathways, and Th2 activation, as well as macrophage activation. So with that, we wanted to, again, study the Central Valley. I was particularly interested in volatile organic compounds. We gave everyone a smartphone so that they could be tracked, of course, with their consent. And what we did was we looked at EPA monitoring sites across Fresno, and this is in the Central Valley. You can see that there are major highways going through the city. Every one of these blue markers is a home, and these are our participants. And you can see that the diameter of the circle actually relates to how much polycyclic aromatic hydrocarbon they were exposed to. Thanks to geospatial mapping, we were able to get individual exposure estimates across years, and we continue to do this study. So since 2009, we've been adding and accumulating data. But importantly, with work that was in collaboration with Berkeley and and Fresno State, we were able to estimate and quantify the volatile to semi-volatile compounds in the air, including phenanthrene, which was one of the highest. And unfortunately, these are also associated with carcinogenic mechanisms. So the most frequent PAH was ambient air, was the phenanthrene and naphthalene. Naphthalene is, if everyone remembers, that's what you get from mothballs. That's what you smelled way back in the day when we used to use mothballs to reduce moth growth in our sweaters. But and unfortunately, that is one of the combustion products of diesel exhaust. The reason why I was particularly interested in the Central Valley is because of the PM 2.5 being much higher in that area, but that area of the country has about 25% rate of asthma and a 70% rate of allergies. And that's doctor's diagnosed and skin test confirmed. So with that, we enrolled 375 children in Fresno. We did spirometry and questionnaires, collected blood, saliva, and urine samples. We looked at 4 parent class polycyclic aromatic hydrocarbons, also collected microbiota from the skin, as well as feces. And then we looked at individual estimate exposures, And we collected criteria: air pollutants, carbon monoxide, nitric oxide species, PM10, PM2.5, elemental carbon, lead, and PAHs. And then we looked at that exposure 1 week prior to their blood, 1 month prior to their blood collection, 3 months, 6 months, and 12 months prior. With that, we looked at the FOXP3 epigenetics. As I had said, the FOXP3 is a locus that is exquisitely modified by pollution. And so here, especially as it pertains to males versus females, that's another part of looking at epigenetics. You really need to disaggregate gender and sex in this case, because of the FOXP3 is an X-linked chromosome. And so we saw that certain CpG sequences, or cytosine phosphate guanine sequences that are methylated by epigenetic mechanisms, are affected by air pollution in terms of percent methylation over years of age. And we looked at whether or not this was sustained. As you know, it's hard to get follow-up visits, but approximately a year later, we were able to get some patients to come back. It does not look like asthma serves as an underpinning towards the methylation rate or absolute values of CpG sequences that were being affected by the air pollution, but importantly, it doesn't seem to change over time. We also looked at the FOXP3 locus specifically in cells that were isolated as CD4 positive cells. And you can see here ozone, which you would expect to be very different in the summer months compared to the winter months, that in the winter months in the Central Valley, you have higher amounts of air pollution. And that was really mostly associated significantly with the FOXP3 methylation with carbon monoxide, nitric oxide species, as well as PM2.5 after about 3 months of lag time with the blood collection. So here you can see, even moving forward with polycyclic aromatic hydrocarbons, not just PM2.5, the associations we found in the FOXP3 methylation at 3 months versus 6 months, specifically in asthmatics compared to non-asthmatics. And we're continuing to do these studies. So in general, the mechanisms that we found using also animal models was that polycyclic aromatic hydrocarbons linked to the aryl hydrocarbon receptor and create an activation pathway, and that aryl hydrocarbon receptor then moves into the nucleus, binds to certain promoter regions of certain genes, and activates IL-4 and IL-13 and reduces FOXP3 and interferon gamma production. So that's how we think mechanistically air pollution and perhaps wildfire smoke as well is increasing asthma and allergies. So let's get to dust. Dust is a problem now in the Arabian Peninsula as well as Africa. They're seeing increased amounts of days of dust storm. The dusts, unfortunately, are not just irritating for asthma, but they also have meningococcal species, and so people have increased rates of infection now, unfortunately. This was a study that was published by our colleagues in Saudi Arabia, showing that with a lag time of about 3 to 5 days, you can see an increase in asthma rates in certain populations. And not just happening in Africa or Saudi Arabia. You can see here the dust storms, for example, in this particular dust storm in 2020, this actually affected Florida, Texas, and Georgia to be exposed to unhealthy levels of air. Now let's move on to pollen. So unfortunately, as many of you remember from your ecology in high school, that CO2 plants take that in, and especially during the day. So CO2 is actually something that increases plant growth, especially grasses and ragweed. So unfortunately, parts per million of CO2, as you see here, we're at about 419 now. We're seeing increased pollen production and pollen plants in particular. And then the CO2 alone biochemically allows the plants to emit more pollens. And because of the global climate change, for example, you're going to see areas around the country that have ragweed plants for which there would not have been ragweed before, for example, in areas of Denmark or Norway. And that also is going to increase pollen-induced allergies and asthma. This is a paper that was published by Alison Steiner and her group. And again, you can see here, because of the CO2, we are going to have both increases in plant growth, specifically grasses and ragweeds plants over time. We showed the same effect in the Bay Area. And I still see patients, and my patients were complaining every year that their pollen allergies were getting worse and worse. And we tracked this and found it to be associated with CO2 temperature rises. And we showed an increase in 8 to 9 weeks over a period of 2002 to 2019 of the pollen and mold seasons. So thunderstorm asthma is a complicated feature to climate change as well. You have pollen that can be emitted in the air, and with electrostatic conductance that will pop the pollen even more. And in areas around the world, you have thunderstorm area increasing. This is a particular complication in Melbourne that occurred in 2016, where there was a high rate of admissions to the hospital. They just could not deal with that burden, and unfortunately, people passed away. Heat is another complication of climate change. Many studies have been done to show that there's epidemiological evidence now of asthma exacerbations increasing with heat. And this is a meta-analysis, but mechanistically, there are many associated mechanisms to explain why these extreme weather conditions, whether or not it be cold or hot, can activate biological pathways associated with asthma inflammation. This is a summary that we put together in seminars in immunology recently with Steve Galley and others. And so we're showing here all of the different mechanisms, and I'll share my slides with everyone. I won't go into this in detail, but with all of the different issues between pollution, heat, thunderstorm asthma, and dust storms, you can see many of the NF-kappa B pathways, heat shock protein, reactive oxygen species being activated during climate change associated events. I'd like to move on to solutions now, the remaining of the talk. And I don't want to be seeming like a Debbie Downer, but I also don't want to paint a rosy picture without really showing a balance. I think there are a lot of positives now, thanks to the Inflation Reduction Act in the US, thanks to a lot of policies moving forward in the EU. The youth movement is active. There are many areas of the world that have the sales of EVs increasing, and 50 plus nations have now signed a decarbonization memorandum of understanding for their healthcare systems to go to net zero, but we're not there yet. We still need a lot of traction and a lot of changes to be able to make it to net zero by 2050. So Mary Johnson is pictured here. We have a program project grant thanks to the NHLBI, in which we're looking at population level and individual level solutions and trying to quantitate those as we move forward with analyzing our data in the Central Valley. And I'd like to talk a little bit more about adaptation, because I think that's of essence when we think about taking care of patients. Many people ask me when they're exposed to wildfire smoke and air pollution, what can I do? And so there are studies, unfortunately not enough of them, to be able to show that using N95 masks, making sure that you can exercise with limitations, staying indoors if you can, will reduce your chances of exposures. This is again from that New England Journal article for wildfire smoke, explaining some of the personal actions one can adapt to, but they all depend on access. So you can relocate if you have someplace to relocate to. You can close the doors and windows if you have central air, great. But if you're a worker, an immigrant worker out in the Central Valley, unfortunately, you might not necessarily be able to relocate. You might not have a home with HEPA filters in it. So staying indoors, avoiding heavy or prolonged activity is the next stage of suggestions for adaptation to wildfire smoke, for example, or wearing a face mask. But that's, again, assuming that people know what type of face mask to wear. And over on the right-hand side, you can see that the N95 mask is really the best one to wear outside if you have to be outside in wildfire smoke. Unfortunately, a surgical mask or a synthetic mask, or what some of the firefighters wear, for example, bandanas, are not going to do the job. When you look at filters in your home, you really have to be careful. MERV 13 is really the best, but you have to change that out frequently if you live in an area that has a lot of wildfire smoke exposure. HEPA filters can work, but when we look at HEPA filters and explain some of these mechanical issues and engineering issues to our patients, please remember that a lot depends on the machine flow, what square footage the machine is put into the room, and what type of filter the machine is equipped with. And this was a study that was published in 2011, and that was a while ago, but I wanted to focus on it because as we think about looking at measures to adapt with air filter use, we can't just suggest to our patients to use a filter. We also have to help with understanding why that filter is important. And so this study showed, even though it's small, that with a health coach was trying to explain why the filter is important and what it can particularly help them out, particularly with asthma symptoms, that helped reduce the overall PM 2.5 level, for example, in this particular household study. So again, education plus an adaptive device is helpful. Wanda and Petros and Diane from our group, as well as many others, published this back in 2017, where they looked at schools and classroom characteristics, both old and newer schools, and put filters in during the academic year, particularly in the fall, winter, and spring. So it was not for 12 months. They did follow-up. And in that, they showed that PM 2.5 in the air cleaner group was less, and the carbon was also less. So this was a great study to show that. But you can see over time, when the filters were not in the classroom and children returned after 12 months to an area where they did not have the air cleaner anymore, that the symptoms all regress back to the mean. So importantly, is there were differences in symptoms. I think Wanda and her group have done excellent work here, and I'm hoping to see more out of these types of interventions. The next part of the solutions I want to frame for us is really thinking about the fact that our health is inextricably linked to the health of the planet. And that's really in the concept of One Health, which is being discussed by the World Health Organization and others. But when we think about traffic-related air pollution and think about mental stress, in some studies, they have shown that when there are areas in green, not only is that going to help reduce carbon dioxide and sequester carbon as well as clean the air, but it also can help mental stress in individuals and increase cognitive function, which was the outcome in this study. What I found interesting here in terms of the immune system, which we all know very well, but this was a small study. This was a group in Finland where they controlled a group where they looked at nature-oriented daycare centers. They planted more grass. They had children play in the dirt for 28 days compared to cement, and an urban daycare center that they controlled for many different factors. But what they showed, even within 28 days, when the immune system started to change to increase TGF beta, Tregs, and IL-10. So again, small study, but interesting. And when we think about other solutions with switching diesel buses to electric buses, I find these types of studies really interesting, and we need to do more of them, especially as asthma physicians, to look over time at municipalities where the EPA has given subsidies to those areas around the country, especially in public school areas where the diesel school buses have switched to electric buses. To what degree will that improve asthma rates over time? And that, I think, will help policymakers know where are there vulnerable populations, where are there not vulnerable populations, how much time do you need to take to be able to see these effects, and how long do they last for, are going to be all critical questions by which to help policymakers make decisions about switching out diesel to electric buses. When we think about other areas of mitigation, one of them, especially for wildfires, is to do more forest management and prescribe burns. So the EPA and many other regulatory agencies wanted to know more about, as well as communities, to what degree, when they do prescribe burns with forest management, will that affect people's lungs and their immune system. And so luckily, we actually had data, because we had been studying the Central Valley participants for a long time, since 2009. We could actually clock when there was a prescribed burn in that same area versus when there was a wildfire. And luckily, we had samples from those individuals that had been exposed to a prescribed burn compared to a wildfire in the same radius of exposure. So it's a small group, but importantly, we could be able to then compare those individuals with either the effects on asthma or effects on their immune system. What I wanted to show you here was that with the prescribed burn compared to the wildfires, you can see the changes in the criteria air pollutants here in wildfire versus prescribed burn, and this was collected by EPA monitoring systems across the Fresno area. And then you can also see over on the right the percent differences in the Th1 cells. So this is consistent with some of the data showing that with wildfire smoke in particular, there was an increased risk of COVID, for example. This might or might not be the mechanism. You can see with the prescribed burn that it was less. And moving forward on solutions, I've talked about many today, from adaptation of filters to adaptation of masks to adaptation in terms of mitigation in the forests. But importantly, on the global level, how do we do more research with communities, and how do we make sure that we hear community voices and understand to the extent that this is affecting their lifestyle and quality of life? So our colleagues at the London School of Hygiene and Tropical Medicine have done a lot of work in climate and cities and children. They researched many households and did questionnaires and looked at cognitive development, learning, respiratory infections, and asthma. And in this group across these cities, what was interesting is that thanks now to policies, 40% of the individuals that were questioned reported that their city was better to live in compared to those that did not say that and were worried about the future. But what Andy Haynes and his group at the London School of Hygiene and Tropical Medicine showed is that if we can get to those net zero projections in 2050, that you can see the total cases averted in 1 year, for example, for asthma across these different cities. I want to point out LA there in terms of cases averted for 1 year. And why I think this is important for us as healthcare professionals, so that we can tell our patients why going and reducing the need for fossil fuel and increasing renewable energy sources and reducing greenhouse gases, why that's important for our health, as well as many other areas outside of just asthma. But when we talk to policymakers, we need to put it in their language as well. And so in that, there's also been benefit cost analyses done. And this was a publication that came out of Ricky Pereira out of Columbia University and Patrick Kenny here at BU. And they looked not modeling, but actually at the effect of recent EPA regulations. And this was switching diesel to not electric back in the day, because this was before electric buses were systematically available. This was a switch from diesel to ultra low sulfur diesel. And so with that, they were able to use mapping programs from the EPA, and they looked at cumulative health benefits, and this is just for children. And so what they showed is that for every dollar spent on reducing greenhouse gases from EPA regulations, that it saves 6+ in terms of co-benefits of healthcare, both acutely and chronically for families. And why is that important? Well, when we look at other countries, for example, in East Asia, the co-benefits are much bigger because of the issues that are increased with air pollution currently in East Asia, for example. So right now, and this was published by Jonathan Patz and others, that the economics show that if the cost of cleaner energy is about $30 per total CO2, what you get in terms of co-benefits is about $200 for every 30. So in general, what we're trying to make sure that we promote with policymakers as well is for them to see the economics of this. And this occurs in a timeline of about 28 days after changing a bus from diesel to electric, for example, or switching out and reducing diesel emissions. And in our just nearby, with the New England Journal being very close to the Brigham, to the Mass General, and to all of us here in Boston, I want to really give a shout out to what Renee Solis and Karen Solomon, Regina LaRoque, and Eric Rubin now have catalyzed, and Jeff Drazen as well, who's part of our department and part of your departments across the Asthma Coalition here in Boston. But the New England Journal has been doing a lot for educating healthcare professionals and advocacy to be able to understand the effects of climate change, specifically as it relates to healthcare systems. And I won't go into that too much, but I'm glad that we have healthcare professionals in our hospitals that are thinking about how healthcare systems themselves can reduce greenhouse emissions that we are unfortunately emitting as a major producer of industry. So I want to get back to advocacy, and I want to get back to having science be the basis of that advocacy. Oftentimes, as physicians, we are reticent to be able to say that we're advocates in terms of policy. We are advocates for our patients, but in that, as we begin to exchange our data with policymakers who dearly need science to be able to make informed decisions, I want to give you this example that occurred in the Central Valley. After going to the community, asking them what they needed, they wanted to understand how the air pollution was affecting their children and wildfire smoke. And thanks to many knocks on the door of the town council, we were able to show the epigenetic changes that were occurring. We worked with the local high school to have a community-based participation in many of our studies, and they're still ongoing. And the high school student is shown here who made our symbol of the CHAP study. This was funded by the NIEHS and the EPA through our Children's Environmental Health Study. But we also used other people's important work that had been published showing that when you reduce diesel to an ultra low sulfur diesel school bus, that reduced the exhaled nitric oxide with these particular children that had severe or persistent asthma. So it's a 30% reduction. And so over 2 years of knocking on the door, we were able to convince the town council to switch out their diesel buses to all electric, not just for the school buses, but also for the city's buses. So I'll leave with this. As we think about these solutions, we need to quantify them and track them better. And so I think this concept of the exposome is going to be important as we think scientifically to understand and clinically how to frame this for our patients. That looking at climate change, air pollution, and asthma, we've talked a lot today about that. There are many people studying this as to monitoring and managing and measuring, but we need to look at our cutting edge science and bring it to the clinic. And looking at these exposure analyses, I think it's becoming more and more relevant to collecting human samples and multi-omics, that we can look at composite biomarkers over time, that it's going to be important to look at multiple exposures, not just one exposure at a time, because any one individual is exposed to many things. And not only that, it concatenates over their lifetimes. Looking at longitudinal exposure is going to be important. And then looking at intergenerational exposure. So I'm really excited to speak to you today and to be part of our discussions. And I want to thank you for your time. Importantly, I'll leave you with this, which is in the policy brief that many of you might be involved with, the Lancet Countdown, that helps policymakers use science and use healthcare data to be able to inform their decisions. And using transitions to healthy, sustainable practices, removing fossil fuels, talking to the community, finding out their needs, increasing access to healthy transport systems, strengthen the public healthcare system, talk to policymakers when you can, invest in healthy recovery and prevention and green buildings. We have 90% of our lives are in buildings. So I think I want to stress that we need to look at the outside, which we've talked a lot today, but we also need to look at better care for indoor buildings, including our hospitals and clinics. So I'll leave you with this, that we need to build a better future and leave no one behind. We've seen a lot of the catastrophic areas around the world that have unfortunately suffered from climate change. Here in Boston, we've had less than most parts of the world, but we can think proactively about helping our communities here, as well as our patients and the globe. So I want to stop there and thank you for the Mass General Brigham Asthma Center for inviting me here today, as well as thank you for my training and thank you for allowing me the time to discuss with you today, and for our patients and sponsors that are listed here. Thank you.
Thank you, Kari. That was just a wonderful, the breadth of what you've done, both in terms of the basic biology and the epidemiological and public health things. It just is really so impressive. So there are several questions in the chat. One of the questions was, have you or others studied the impact of wildfire smoke exposure on pregnancy and pregnancy outcomes?
Thank you so much. And again, a lot of this research is really part of a team. No one person can do any of these studies. And yes, my colleague Marshall Burke and many others have published data showing that unfortunately wildfire smoke induces preterm birth. And we are now currently studying effects of wildfire smoke on pregnancy and getting ready to publish that data. But in general, the state of pregnancy versus non-pregnancy changes your sensitivity to wildfire smoke as well as air pollution. So I think we need to look at pregnancy as a state, but also over time, whether or not being pregnant affects how a woman, when she becomes non-pregnant, and how her immune system is affected by wildfire smoke. So yes, we're watching that over time, but so far there's data now to show preterm births are associated with wildfire smoke exposure even after 5 days during someone's pregnancy, as well as unfortunately miscarriages.
Okay, and then there's another question. Would you predict any effect of air pollution on gut or respiratory microbiome?
Great question. So you can infer that. I think Lisa Miller at UC Davis has been looking because she had a colony of primates that were unfortunately exposed to wildfire smoke at UC Davis near Sacramento. So I'll have to ask her that question as well. Right now, we do have access to that microbiota from the Fresno patients, so we'll be looking at that. I'm not aware of any particular study on the gut yet. There is a study that came out in JAMA showing that increased exposure to wildfire smoke induced atopic dermatitis. But of course, that's skin. So one might infer that by breathing in and swallowing the wildfire smoke, you could have affected the gut epithelium, but that would just be hand waving at this point.
Okay. Then closer to home, there has been, as you know, a effort now to begin eliminating HFAs. And can you comment a little bit on the contribution of medical HFAs, especially in terms of our asthma inhalers, and where you think that's going and where we should think about going with that?
Yeah, it's a great question. Thanks to the person that asked. I was hoping someone would ask that. Yeah, I think we have to do better at looking at any medicine that we use. HFAs very much being the direct measurement of making sure that we can use different devices to help our patients with asthma. And with that, we've been looking at EPIC and looking at ways to put sort of green markers near those medicines that are more ecologically friendly to the planet, and that through their manufacturing pathway also were ecologically friendly. And so we're working with EMR companies, and particularly, this is not me, this is a student group that has moved this forward with EPIC, to be able to think about laying out a program by which when physicians and healthcare professionals prescribe a drug, you'll be able to be notified right away to what degree does that contribute to planetary illness, as it were, in terms of CO2 production. So I do agree with whoever asked that question. I think it is possible, and I think we need to go faster. I did have an article that we published in Europe recently showing that we can change those HFAs and devices. I don't know. What do other people think? Do people feel strongly about this as asthma physicians?
There's an initiative at MGB to begin actually thinking about this. So I think one of the I don't know if you've thought about this or others. The question though about how this impacts actually on countries with low resources, because what's happened every time there's a switch in terms of these propellants is that there's new patents and the costs then climb dramatically, and the availability of these drugs for under-resourced countries really falls dramatically. The cost of a ICS LABA in under-resourced countries can exceed one month's ICS LABA can exceed 1 month's of the average income in many countries, and so this will only get worse. And so how does one balance that? In terms of thinking about policy considerations.
Totally agree, Elliot. This is where, the unintended consequences of these actions, we need to think ahead down the road so that we don't wind up making those that are under-resourced even worse in their access to healthcare. I do know that the 50 healthcare systems that have signed on to going to net zero by 2035 to 2050, and even some by 2025, for example, the National Healthcare System in the UK, by doing that, they also, the 30,000 manufacturing companies that then supply their supply chain also have to go green. So with that, as we think about other countries doing that, then I think that system will pressure the pharmaceutical companies to hopefully not do what you said. But I think you're right. We need to really be careful about that and be thoughtful and think ahead with policymakers. Thanks for bringing that up.
Sure. There's another question. Is there any evidence for masking or N95 use or other respirators during acute wildfires to mitigate the effects on children?
Great question. Well, up until COVID, unfortunately, 3M, for example, didn't even have a really well-fitting N95 mask for children. So, you know, I guess in a skewed way, COVID helped us get better fitting masks for all ages. But with that, it's still hard, as we all know as clinicians, to really make sure that a child is wearing a mask, an adult, nevertheless. But there's no specific studies that have been shown for children wearing masks yet. Everyone is just inferring from that N95 data in adults that reduce the likelihood of PM 2.5 exposure. Volatile organic compounds, for example, can still get through an N95 mask. So even if you're wearing it well fitted, you can still get volatile organic compounds in. So to answer the question, no studies that I know of right now have been done specifically in children to be able to assess PM 2.5 exposure. Hopefully, we'll see similar data to adults, but we don't know because of movement and of ill use of ill fitting of the mask.
Okay, another question is, do we have an effective way for patients to monitor their exposures on an individual basis? Apps that can be used to integrate BPA reporting for location in real time, or evolving methods for actually measuring them in ambulatory wearable monitors. Is that something that we should consider advocating for our patients?
Yeah, I think in well-resourced areas of the world, you know, if you go on Amazon, you can get some fairly high-tech, rigorous, precise monitors that will monitor temperature, CO2, pollution. You can put them in your room. There are wearables now. You always have to be careful of that. And I don't want to just, you know, tell our patients to get data for the sake of data, but actually have it be useful and monitorable. And I think as physicians, we need to hopefully at ATS or at Quadruple AI or other conferences really think, or through the national academies, come up with a list of best buys for what monitoring system might be appropriate. But just like what's happening in some states, for example, the air filters in California, where we knew that that would be really helpful to have, especially as many people are indoors and in schools, we were able to prescribe air filters and get that reimbursed by insurance companies. But not every state has those policies, or a third-party payer has those policies. So I'm hoping at some point we can get purple air monitors, we can get these personal monitors reimbursed by third parties, because it will help, just like monitoring glucose, but we're not there yet. But I think collaboratively we can push for that. There are some really nice monitors. If people want, I can share that with you, Elliot, and you can share that with our colleagues here in the audience.
That'd be wonderful. That'd be great. And then another question was, are there major changes in airway susceptibility to inhaled air pollutants over the lifespan? Very young, very old? You showed things with the young. How about the old?
Excellent
question.
Diseases. Yeah, exactly. As we all get wiser at our age, over the age of 65, unfortunately, even after 3 days of exposure, we thought, okay, would it increase their respiratory disease? But what I think people are finding is that as people get older, not only does it affect respiratory issues, but most importantly affect cardiovascular. So there's an increased rate of MI. In some studies, they've shown a 48% increase in MI even after 3 days of wildfire smoke exposure, 100 AQI. With 65 and over, and then a 12% increase in stroke. So I think the endothelium also plays a critical role here as people get older. But yes, there are studies being done. And I think, again, we need to look at it from a solutions framework too, as our population across our country does get older, and we think about ways to mitigate their exposures.
Well, that's great. I think we've reached the end of the hour. This has been an unbelievably stimulating talk. And again, just congratulations on the wonderful work that you're doing. And if you do send me the information, we'll post it on the website
Okay.
that people can look at. And just to tell you, all the comments have just said how impressed they were by the talk, and congratulations on the talk.
Oh.
So thank you so much for a wonderful talk, Kari.
Thanks.
And keep up the great work.
All right. Thanks for inviting me.
Okay, take care, everybody.
Okay,
Okay,
thank you.
see you next time. Bye-bye.
Bye-bye.